Dr. Abdelhakim, I guess my first question is, ophthalmology is the study of, vision, and in particular in relation to health. What drew you to that field?
What I really liked about ophthalmology is that it really drew in a lot of different kind of aspects of medicine to it. So you get to work with both adults and children in ophthalmology. You get to think about not just the eye, but the systems that connect to the eye. So the brain, neurologically, how does the eye function? How does it interface with the immune system, how it interfaces with all sorts of other things. And the complexity of the eye and just its anatomy was just really kind of very interesting to me. And then obviously from, it's one of the most, it's the most important sense, I think. And maybe I'm biased, but my own dad had visual issues, and I could see how visual impairment affected his everyday life. And that's actually one of the most important reasons that I went into ophthalmology, is because I had that personal kind of insight into how, a vision can be super important for you, just, going around your everyday things.
Yeah, and obviously we think about vision as something that's very important for primary visual things like navigation and reading and things like that. What are other domains of life that can be impacted if somebody has subtle vision changes or experiences deterioration in that way?
Sight is it's linked to so many things, not just, reading or writing, but just kind of your emotional state. You can see something and it brings up certain emotions, or it kind of makes it's social kind of interactions. It's so memories. It can bring it's just so complex and brings in so many different aspects of just living. Yeah.
And I think one thing that I've heard a lot from this community, or at least several times, is conversations where there is kind of a paradox wherein when you have more severe symptoms, it's easier to characterize and see. And so I think when somebody has very severe vision loss, it's something that might be easier to pick up on. But I know that we have several parents in our community who have kind of came to a slow awareness about what that vision loss was, because it was more subtle. I was wondering if you could speak at all to, are there yellow flags that might be associated with looking out for vision loss for somebody who doesn't have evidence of it yet?
Yeah. So I think a lot of the time when people think of vision, they think of can I read the letters on this chart so many feet away? But, vision is so much more complex than that. So, there's that aspect of it called visual acuity, how sharply can you see at a certain distance? But there's also things like color vision. There's field of vision, basically on your side vision. There's stereo vision. There's contrast vision. There's all sorts of different types of aspects to vision that people don't always necessarily think about, but rely on a daily basis. So, some things that I've heard from families, with kids who might have really good visual acuity, they have 20/20 vision, but they say things he has a hard time going down the stairs, which could imply things issues with stereo vision or issues with field of vision, because you need to rely on both your stereo vision and field of vision to navigate around, not just visual acuity. Or, my kid would have a really hard time, if they drop something on the floor and the floor is patterned, they can't see where it is, even though it's right there. And if that's probably an issue with contrast vision, if it's a patterned floor and whatever they dropped is kind of similar to the floor, then you need contrast and kind of detect it and take it off the floor. So there's these kind of subtle things where visual acuity does not necessarily pick these things up, but that may indicate something, some issues with certain aspects of vision in that individual.
And so it sounds like those individual stories that are about, one event that happened that was a little bit off, that can carry a lot of information about what kind of processing is actually disrupted.
Yeah, and what kind of what aspect of vision is being affected.
Yeah. And with that, I do want to turn it over to you, Luke, because you have had personal experience. And I was wondering what was Susanna's journey with vision, and what was your journey kind of coming to the realization that Susanna was struggling with vision?
I just met our amazing family from Portugal, and the answer, she asked a question and Dr. Bain said, we just don't know yet. And she said, I don't like that answer. And so the answer is one that I don't like either. And it's just that we've gone through we saw on her brain MRI, we were able to see that her optic nerves were changing. So we knew structurally that that was happening. And then she would say things like, my eyes hurt, or I'm seeing thing, and then we thought, well, maybe she's having a seizure. And then she's lost some peripheral vision, but it's terrifying to be able to, hopefully give our kids this great life. And it's not fair to take something away from somebody, especially like vision, and so our experience with it is we don't know how or why. Some people will tell us it's cortical vision impairment, which I really don't understand, by the way. And other people will say it's optic nerve atrophy. And some people will say it's, the strabismus, which we know she has. And we don't want to have an invasive surgery to fix something that's, aesthetic, but we just don't know. I bet it's terrifying. Like all of you, I've talked to so many people about vision, and if we were to rate things that we're so scared about, one of the top ones, is my child going to lose her ability to see, and I imagine I would ask all of our community, that's got to be one of the top ones for all of us, right? I mean, maybe not, but for me it is. And so the answer is one, I don't know, and I don't like that answer. I don't know if that helped, but
I think it did. Yeah, I think that's the reality. It's hard, and there are a lot of people in our community who struggle to communicate vision. And even as somebody with a lot of language at my disposal to describe what I see can be a difficult thing.
We've started to, she still has vision, she can still see, but we've started to teach her Braille. And, just that, and that preparation is kind of, exciting, because we're making sure that she will, if things progress in a certain way, that she'll be able to navigate the world in a certain, way. It's not, people can live great lives, but we're teaching her Braille when she still has vision, because we don't know what it'll be like next year, and I don't know. Do you know?
It's really hard it's very difficult. And like you said, like things like, terms like cortical visual impairment, like even a lot of ophthalmologists don't really understand like the basis of that, even though like it's, patients have it and it's real. And like, it's really difficult to comprehend because the visual pathway is so complex. And like, it's just, like I said, it interfaces with the brain in such a kind of like intertwined way that like, it's just, there's still a lot to be learned about those visual pathways and like why these things happen, or cortical visual impairment, what does it mean? So we're trying to get at that. And it's hard, it's hard to know what all of that means sometimes.
Well, and let's talk about that process, because what we're talking about is getting from the perspective of subjectively what is my family member experiencing, to how do we actually get into the physiology and figure out what's biologically going on. And I think one thing I'm curious about is many people here have experienced going to an ophthalmologist and not necessarily seeing something or being told not to worry about it. And I think that's because there's a stepwise approach to ophthalmology, right? There are other assays that you can add. And so I was wondering if you could talk a little bit about what entry ophthalmology appointments might look like. And as you're going more in depth and trying to get more nuance, how do you start to build out additional ways to look at vision?
Can I interrupt for a second?
Oh, yeah.
My interruption is just going to be really quick. It took me a while to get this. Assay means experiment.
Oh, yeah, thank you.
Anyway, yeah.
Yeah, so we tried to basically get at that exact question, like, what are the best kind of assays to kind of, identify the issues that the patients are dealing with, and like, to quantify or like try and like put into some sort of like objective way what they're perceiving, how they're perceiving their world. Like, because, when we started out, there was really very little data about how patients were perceiving their world. A lot of it was just like, if you went into the literature, it was just kind of like, first of all, not, many of the papers out there looking at KIF1A, they didn't really have any information about vision. It was mostly like, mostly neurological, kind of like, spasticity, that sort of thing, but vision wasn't really mentioned. And then the ones that were mentioned, it was just like a yes or no, optic atrophy or no optic atrophy. And that was it. And like optic atrophy, I mean, like there's a huge spectrum of optic atrophy. Like the term optic atrophy, almost kind of like it just, it contains so little information because it's not a yes or no thing. You can get mild optic atrophy, you can get severe optic atrophy, there's everything in between. And even optic atrophy in itself doesn't necessarily mean like, significant vision loss. It's just kind of like, so you can see that the nerve, there's like some, is affected in some way. So that's all it really means. So we basically wanted to kind of quantify like all these other aspects of vision and come up with these assays. So basically, if you go into like just a regular ophthalmology appointment, if it depends on whether you're an adult or a pediatric ophthalmologist, but pediatric ophthalmology it's kind of tough because like kids just don't like to have lights shone into their eyes. It's really a difficult exam for them. They don't like drops going in their eyes. Like even adults don't like that. So it's really tough to like really get like, the best exam in kids sometimes, but like, what you would expect to do, or like what a ophthalmologist would do is like make sure that they're seeing well, make sure that their eyes are aligned, make sure that everything at the back looks good, the optic nerve, the retina, that sort of thing. And like sometimes it's hard to quantify because like you're getting just basically very limited vision of the optic nerve. So it's hard for some of these pediatric ophthalmologists to like really say yes or no optic atrophy and what it means. So what we're trying to do is like, with the patients who are able to, go through more kind of, I would say like, assays that are a little bit tougher to like sit through. So like, what do they look like when we try to image the optic nerve? Like how much optic atrophy is there? We're trying to do things like, something called the visual, VEP, visual evoked potential, which looks at the communication between the eyes and the brain, like kind of like how fast are the signals being conducted, and like, what it means. We're looking at color vision, field of vision, that sort of thing. So to kind of get a better look at what these patients are perceiving, which is what is important. Like you want to know what your kid is seeing and like how they're navigating their world. So, so there's a lot of information that we got from that kind of like approach. I can go into it if you want me to, but like, does that kind of answer your question? Or?
Yeah.
Well, I was just gonna say, I would love to go into that. I was just gonna say that something that really helped Susanna, that I'm not sure if everybody knows that you can put vision therapy into your IEP, and that's really helped Susanna, is that there's a vision therapist that works with her at school. And so when you're going into your next IEP meeting, even if there's not vision problems, yet, or there ever will be, ask for vision therapy. Why not? You can ask for everything in your IEP meeting and throw that in there. That helped us a lot, is in understanding how she sees things every day at school, how she has to use a slant board because that's easier for her to read. And we didn't know that until she had her vision therapist in school. So I would urge everybody, when you're working on your IEP or special education, to really try to advocate for a vision therapist. Just.
That's actually a really great point. So definitely that can really help, the individual navigate their surroundings better. Like there'll be exercises, they'll like basically tailor it to whatever difficulties, the patient is having. So that's a really good point. Yeah, thanks.
And yeah, I think this would be a great opportunity to step into a little bit of the findings. And I think that's a great opportunity because as you're looking through this, think about whether this is stuff that might be reflected in your experiences, or if there are things in your experiences that aren't reflected up here that you'd like us to know about. This is a great opportunity to kind of do a comparison and contribute more information. So yeah, I think that would be great.
Yeah, so basically, these are kind of like, the general findings are, in terms of the different aspects of vision. We found that for the most part, in terms of visual acuity, looking at something and like, is it sharp or not? Or, can you can you discern something in the distance? A lot of, patients with KIF1A, they actually, hang on to pretty decent visual acuity for quite some time, and even into adulthood. So it's like only a little bit, on average, only a little bit affected, which is kind of promising. But of course, there's obviously variation from patient to patient, and it kind of depends on the variant that you have. So this is not like it's not like for everybody, but like in general, that's what we found. But what we also found was there's like some other aspects that we didn't, realize before. So for example, most of patients with KIF1A have issues discerning color, which is actually not, it's not something that is unexpected with optic nerve issues, because optic nerves, it's kind of optic nerve atrophy and color vision are very kind of closely intertwined. So, color vision tends to be affected. Field of vision, is also affected to some extent. And then also like using more advanced ways of looking at the optic nerve, such as something called optical coherence tomography. We found that that's a more sensitive way of looking at optic nerves, instead of just looking at them subjectively and saying, oh, there's optic nerve atrophy or there's not, which is subjective from ophthalmologist to ophthalmologist. You can do it more quantitatively, and more importantly, you can like follow it with time and kind of like get a sense of like, how fast is the vision getting affected? So we found that to be very, very helpful. So if your ophthalmologist has access to imaging like that, and you are able to use it, then I would recommend that, kind of like to have a baseline and then see how it changes from year to year. So it's kind of like some of these other aspects of vision are, definitely affected, but like, some are less affected than others. So that's kind of like, what we've been finding with different patients. We also found that strabismus is quite common in patients with KIF1A. So 40% of patients with KIF1A do have a history of strabismus or have active strabismus. That strabismus is basically when the eyes aren't working together or are aligning together to give you stereo vision. That's called strabismus. So it's pretty common, something to ask your ophthalmologist about. If you're following with an ophthalmologist, is to carefully follow them for strabismus. Refractive errors are another thing that we've seen. So refractive errors are common just in general. In patients with KIF1A, they tend to have things like astigmatism. Astigmatism is basically, it's a refractive error, meaning you need glasses to correct that error. So it's not an error that's like, it's not kind of like, we don't think of it as kind of like a big deal kind of thing, because you can correct it with glasses. So, or they have like hyperopia or myopia, meaning they're farsighted or they're nearsighted. So just things to kind of like, think about and ask your ophthalmologist about, like refractive errors, the risk for strabismus. Do they have like imaging, like optical coherence tomography that they can help follow your kid or your relative with? So, and then, things like to watch out for, like, color vision can be impacted. Patients don't always know, or like patient families don't always realize that. And field of vision. So things like, vision therapy can be super helpful with things like that. Kind of like learning how to like, use the field of vision that you have to maximize, it in a way so that you can navigate your world safely. Yeah.
Does fatigue, but sorry. I know a lot of our families have, at least Susanna used to have a very specific time where she would hit a wall of fatigue and her day would be over. And I'm wondering if you see it, does that extreme fatigue play a role in vision?
Absolutely, but that plays a role with all kids, with not just kids with KIF1A. So it's just ophthalmology exams, or like, just kind of like it's demanding for the patient. It's like it requires a lot of ability to go to like, focus and like, don't let things like bright lights bother you, or like you'll tell the ophthalmologist asking you to look in certain directions. It's like, it's hard. So even for patients who don't have, it's difficult. Yeah.
Outcome from an exam at 10 in the morning different from the outcome from an exam at 3 p.m. or something that you found with KIF1A?
I haven't noticed that really. I've seen, you know, patients come in and like they have no issues, and like patients who do, but like I don't think it's related to the time of day or anything like, yeah.
Yeah, I think a lot about when you talked about loss of color vision, you know, the first thing I thought about is colorblind people who don't realize they're colorblind for a long time. And also, you know, when you're learning new vocabulary, one of the first things that you learn are the colors, right? And I was just thinking about trying to distinguish those, you know, when you can't really distinguish them. Does, you know, having heard some of these symptoms, does anybody have individual stories of their experience with vision or things that they'd like to share about their experience? Yep.
So, how would I get vision therapy like for people at home? Because they, people at home are really, they can't really see as much as they want to. So do you know how I can help them to get vision therapy? Or would you Google it, or would you call somebody, or would you, how would you do it so people at home can get it too if they need it?
So just so I know, so that I understand, you're asking about vision therapy and like vision therapists coming to your house. Oh, so
How would you, like, if my friends at home need vision therapy, do they come to your house, or do you go to them, like physical therapy, like OT? Yeah. Like, do you go there, or do they come to you? How does that work?
So first, I just want to say, Janie, what an amazing person you are, because your question, how I heard your question was, how can I help somebody else? That's how I heard your question. And that's incredible. I can only speak, and your mom is an incredible advocate. So I would say, talk to your mom about that kind of advocacy too. But, you know, I would say it varies from state to state. You know, and I think that I'm certainly not an expert on vision therapy in certain states. But in New York, it's there are, well, Lighthouse doesn't really exist anymore, does it? So you are incredible. I mean, anyway, you're incredible, Janie. So that's my answer, is that as far as I know, it's regional about access to vision therapy. But somebody might have does anyone have a better answer than me to help Janie help other people?
Sorry, I'm from Canada, and as soon as you mentioned it, first thing I did, I hopped on my phone and I'm vision therapy in my area. And there was just an optometrist that offers it for us locally. So I'm going to call them when I get back. So I'm thinking just Google. Yeah.
You can get it mandated into, oh, I don't know about Canada, but in the US, you can get it mandated into your IEP. So slam it home and own, that's part of the whole own your IEP. You can have doctors come, you can have anyone come to your IEP and get vision therapy in there, you know? So,
yeah. I just also want to say that there are optometrists out there. They're called low vision optometrists, and they don't just exclusively work necessarily with people who have low vision. It's just basically what they do, or what they specialize in, is patients who have some, you know, any form of visual disability. They kind of like assess the visual disability, try to quantify the visual disability, and then come up with a plan, you know, to kind of like, you know, address that visual disability, and how to, like, you know, basically do exercises or sort of, you know, adapt around that visual disability so that you can maximize the vision that you have. They're called low vision optometrists. And oftentimes they have, you know, their connections to people who might be able to come to your house. But again, like you said, that kind of depends from state to state. I like here, for example, I don't think the Lighthouse does that, but you know, I'd have to like dig into that, but like, I think it depends. But, you know, you probably start out with a low vision optometrist to get down that, to go through that route.
Hi, I'm Catherine. I'm from Australia. And for those listening online from Australia, we have Vision Australia available to us where you can register through NDIS, which is the National Disability Insurance Scheme. And you can get that included in your package for Vision Australia to provide you with vision therapy. So it's something that we're currently waiting for Edward, but it is something that we certainly have requested for him to have. So.
Hi, I think this is a really good time for me to share. You probably remember us because Sophia has extremely poor vision. So I shared my story a bit with everyone, but I'll do a quick recap. Is that Sophia is about to be 17, but she had like a massive episode of something when she was 6 months old. So I've never seen the degenerative side of this. I saw a complete degeneration. So she went to nothing. So she was 6 months old and she couldn't even move her eyes. They were fixed in one point and not a single muscle in her body moved from a child that was moving. And apparently no seizure, nothing. And no one had any explanations. Off we went. Why I love to interject at this point, and it's something I'd mentioned to Luke yesterday, is I feel a little bit like I see all the kids, and because we went from nothing and she is severely affected, but she can do a lot. She can walk with a walker. She can use her eyes now. Every 16 and almost 17 years of her life has been a day of regeneration to me, simply because I don't know if it's because we prevented more degeneration because we threw things at her from 6 months for 16 and a half years to make everything work. Where I lie with the ophthalmology side of things is that is the hardest for all of us, because you can physically make a person's body move. They're going to cry and they're going to scream and you're going to want to give up, but you can physically make your child do things with their body, but you can't physically move an eye. And I think we spent probably the best part of a year just with a little green bell, moving it to try and just make her eye move, let alone even do anything. And as we got into the system of schools and vision therapists, and I agree, you should advocate for all of it, because when your child has some vision, there's something for someone to grip onto. But when your child doesn't have vision, but they're not blind, because clearly something's happening with their eyes, it's really hard for people to know what to do because they can't physically do it. So they do all the same strategies. And in my experience, what I would really say is that there was very little output for a long time. I mean, years, I don't think anything really happened with her for years, but we're at a stage where her eyes do function. I don't think she really sees very much. I think from the testing that we did in the KOALA, it was incredibly hard to even test her on a visual level. But there's a lot she does. And so to me, that means that all the things you do with contrast therapy and light boxes and waving things and using sounds to make people do things, all of those things, they might seem so crazy and difficult and hopeless, but I think it all goes in, because I never have seen degeneration, even though she has no other diagnosis and it's a degenerative disease. Something's being thrown at her every single day of her life to make her progress. So I just thought I'd add that in because it's an incredibly tough one, the ophthalmological side of being able to make eyes work. There you go.
Yeah.
Thank you, Sophia's mom. That was very inspirational for sharing that. I have a question. It's a little more clinical. So earlier we learned that there's overlap with ALS, Parkinson's, and Huntington's and Alzheimer's, and none of those diseases have optic atrophy as part of their clinical, triads or dyads initially out the gate. I'm wondering, are there other, and I know there's a lot of advancements in ophthalmology and other genetic disorders. Are there any other models or diseases out there that involve optic atrophy that we can kind of grab onto or learn from in terms of what we're seeing. And I'll share, it does keep me up at night every time we go to the ophthalmologist and she says, severe optic atrophy confirmed on OCT, but we can correct you to 20/20 and we'll see in a year. I'm kind of like, okay, that sounds great, but it's one of the things that keeps me up at night. So I didn't know, are there other diseases that I should be learning about or partnering with or advocating that kind of parallel what you're seeing in the optic atrophy with KIF1A?
That's a great question. So optic atrophy, it's a very general term, and there's literally hundreds of reasons why an optic nerve can degenerate. The most common reason, like in the world, is glaucoma. So you probably have heard of somebody who has glaucoma. It's like the most common cause of optic atrophy, or it's like a form of optic atrophy where, like, basically it's thought that, high eye pressure or something like mimicking high eye pressure causes the optic nerve to start to degenerate. And there's a lot of research into glaucoma, but even glaucoma itself, there's like hundreds of reasons why glaucoma occurs. And there's like a lot of research going into that. So in terms of like, and there's like within that field, there's like focus on things like, regeneration, like neuronal regeneration, and kind of like neuroprotection. A lot of research going into it just because of how common glaucoma is. So I think I'm hopeful that, like, from that kind of research, we can kind of glean something for other types of, optic, other etiologies for optic atrophy, such as KIF1A. But like, so that's kind of like the commonest form that I could think of. And there's definitely a lot of research into that. There's all sorts of trials going on right now with like drugs that help with neuroprotection and slowing down the rate of optic nerve atrophy. So if it's found to work in glaucoma, then, maybe it can work in other types of optic nerve atrophy. Although again, it really kind of probably depends on the underlying reason why there's optic atrophy to begin with. There's some other genetic diseases that can cause optic atrophy, and like, there's trials going on there with gene therapy. So, it kind of, again, it really kind of depends, I think, really on understanding why the optic atrophy is happening, and then getting at that very kind of the basic reason. But there's definitely kind of more general, neuroprotection trials that are happening right now, and I'm hopeful that they can be applicable to KIF1A as well.
Thanks. From the get-go with Janie early on in her vision, I remember there being what we, for lack of greater clarification or understanding, used to call or still call like blind spots. When she was little and would be trying to do puzzles, like children's puzzles, she couldn't get it. And we were like, oh, thinking it was cognitive, but then you could move it over 3 inches and boom, she'd get it. Like the center of her vision wasn't working, but the side was. And so a lot of times the vision thing gets, I think, confused with cognition sometimes, because these things, unless you catch these things. But I haven't heard you mention like this idea of blind spots or spotty vision.
Mm-hmm.
Is that something that you see with KIF1A?
Yeah, for sure. So that kind of falls under the umbrella of field of vision. So field of vision doesn't necessarily mean just your side vision. It can also include like the blind spot and enlargement of the blind spot. So you probably know the blind spot is where everybody has a blind spot, and it's basically where the optic nerve is. So if there's an issue with the optic nerve, or like, the cells around the optic nerve are affected, then that blind spot can be enlarged and it can affect the vision. And that kind of, the field of vision kind of encompasses the whole field, and that can certainly be part of the field of vision that's affected. And we've seen that in patients with KIF1A, they do have enlarged blind spots, or some, a subset of them do. So that's certainly something that we've seen. Yeah.
Hi, I come from the UK.
Hi.
We regularly visit our optician, as we call them, to get our eyes checked and maybe get a new prescription. And often we get some other kind of investigation. But you said that the sort of the regular optical service might overlook things that are important in the case of KIF1A. So I'm just wondering, is there a simple list that you can point to that tell us, what kind of investigations we really should be asking for or looking for?
So I'm sorry, just so I know I heard, you're asking for like what to ask for from your ophthalmologist in terms
Yeah,
of.
just what kind of investigations, what kind of equipment, what kind of facilities do they need to have to be able to investigate or identify the kind of problems that we should be looking for?
Right, yeah. So a lot of it will depend on how much, the patient can do as well. So, for example, an ophthalmologist may have an optical coherence tomography machine, but that doesn't necessarily mean it's going to benefit that patient, because it needs the patient to like sit at the machine, focus at a target for like at least a few seconds. And that's hard even for people without KIF1A sometimes. Yeah. Sorry.
Yeah. Really, my question was, is there a simple list that you can point to? Because I'm probably going to miss what you're saying.
Oh,
Just
okay.
at this moment.
Yeah, no, I was just
Please.
listing the caveat. I'm sorry.
Yeah. My daughter is an adult, so and her vision is fine, but we just wanted to make sure that in our regular visits to the optician, we're not missing the opportunity to learn in time that there's something's going on. Yes.
Yeah.
So are you able to provide a list, or can you point to
Yeah.
tell us where
Sure.
to find a list of those kinds of investigations that we need to access?
I was going to say, I think this might be something the foundation can work with you on.
Of course. Yeah, but basically, I would say for an adult patient, definitely check visual acuity. That's you'll find that at any optometrist or optician, ophthalmologist. Things like checking, it would be helpful to have visual field machine. That's something that can be helpful in terms of following the optic nerve atrophy. Checking color vision is important. Contrast vision is another thing that you could check. These are all types of vision charts. Like contrast vision is a type of vision chart. Color vision is just a basic, it's like a booklet with different colors, kind of different patterns that you need to pick out. And if you're able to see them, see colors, that you pick out those patterns. And then, what I was mentioning earlier, optical coherence tomography of the optic nerve is extremely helpful and sensitive. It's called OCT for short. So that's something I would ask your ophthalmologist or your optometrist about as well.
Do you foresee at any point in the near or distant future stem cells being beneficial to any of the issues that the vision issues that our kids have, more specifically sibling blood or tissue, cord blood or tissue?
That's a great question. There's a lot of research into stem cell, basically therapies in all sorts of eye diseases right now. A lot of it right now is focused on photoreceptors, which are a completely different type of cell in the eye, and therefore patients with inherited retinal degeneration. So there's a lot of that with stem cells. I don't think that with the optic nerve, it's a little bit more difficult because the cells forming the optic nerves are wired in such a special way that it's hard to kind of we need to understand how to wire them the same way so that they work the way they work. So I would say at this point, probably stem cells, for optic nerve is kind of a ways away, but hopefully with the stem cell research that's happening with photoreceptors now, that can lead to that point eventually. Yeah.
Have a couple of pregnant moms in the group to save sibling cord blood and tissue. Sorry. So do you think it would be beneficial? I think we have a couple of pregnant moms in the group for them to save their newborn babies' cord blood and tissue in hopes that it might one day help with their KAND child's vision issues.
Yeah, I think cord blood tissue, is a good thing to have, regardless. You know, but again, it's hard to say whether stem cell therapy is gonna get there. People are working on it, but it's hard to say when that's gonna happen exactly. Yeah.
Hi, so our daughter Addison was diagnosed with nystagmus.
Mhm.
And I don't notice it during the day, but at night when she's tired, we see the eyes going back and forth, or when she's coming out of sleep. Is that something that will get worse as time goes on, and is it treatable?
That's a great question. So just, you said your daughter had nystagmus, right? And is it going to get worse? Yeah. So there's many different types of nystagmus. A lot of the time it doesn't necessarily get worse. Nystagmus, a lot of the time in patients with KIF1A develops, it's kind of a sign of visual development. So like if the eye isn't getting there's signals that it was expecting in development, then it does this kind of it's looking for signals, which is what this kind of nystagmus kind of comes in. And generally, you can treat nystagmus, with things like glasses, patching, that's what, the pediatric ophthalmologist might do. They might patch, the patient, they might give them glasses, they might even do surgery on patients with nystagmus. So it really depends on the etiology of the nystagmus. I would say for patients with KIF1A, I wouldn't really expect the nystagmus to get worse because it's mostly based on the developmental aspect of KIF1A. So my sense is it would not get very worse with time. Yeah. It usually does get worse though with fatigue. So if you've noticed that your daughter kind of gets it when she's tired, that's definitely something that's been noted before. Yeah.
I was wondering, is it known if there's any inflammation that comes along with the optic nerve atrophy?
Information that comes along?
Inflammation.
Inflammation. Oh, it's not really, it doesn't really look like an inflammatory process when you look at it. There's no swelling of the optic nerve or anything like that. There's no inflammatory cells that are found around the optic nerve, or kind of no kind of what we call hyperemia, which is basically redness around. There's not really any of that, any of those signs that we've seen when we see patients with KIF1A. So I wouldn't say that it plays a huge role, but molecularly, I can't say, but clinically, I don't see that.
Thanks.
I have a question. Somebody just asked me to ask. Is there a chance that you could explain the difference between cortical vision impairment and optic nerve atrophy? That was a question that somebody just texted in, because we all hear both of those terms.
So cortical visual impairment. So optic nerve atrophy is basically a clinical finding. It's something you see when you look inside a patient's eye. So an optic nerve that has any sort of it's kind of has some sort of degeneration in it, you can detect as optic nerve atrophy. So it may look like that layer of cells may look thinner, for example, or it has a different color. That's how you detect optic nerve atrophy. Cortical visual impairment is a little bit more complex because it kind of touches on the interface between the eye and the brain. So, for an ophthalmologist, it's kind of a tough one for an ophthalmologist, because cortical visual impairment, it could be that you look in the eye and it looks completely fine and you don't see anything that is, that is an issue, but there's still some sort of issue with in the communication basically between the eye and the brain, or how the brain interprets the signals coming from the eye. So that's cortical visual impairment is a little bit more complex to kind of detect because it's in kind of the posterior visual pathways. So it's different in the sense that it's in a different location. So optic nerve atrophy is in the anterior part of the visual pathway. It's in the eye, not so much in the brain. It's it's part of the brain, but the anterior part of the visual pathway. Versus cortical visual impairment is a little bit less well-defined. And I'm sure there are many reasons for cortical visual impairment, just like there are many reasons for optic nerve atrophy. So it's a little bit it's kind of I think kind of an umbrella term, and maybe Dr. Bain can also kind of weigh in on that as well from the neurological aspect of cortical visual impairment, but it basically just means something beyond the anatomical part of the eye itself and like the interface with the brain.
Thank you. I think that was helpful.
I think this kind of comes back to, you know, we've heard a couple of times the terms neurodegeneration, neurodevelopment, atrophy, and I think we're in this interesting situation where we have symptoms on one end and we have a cause, KIF1A mutations on the other, and all of these ophthalmological assessments are kind of working backwards from the symptoms to figure out what might be going on. And the other piece of that is figuring out mechanisms, right? And that comes down to what diseases do we look to for, you know, advice or correlates, and what can we expect from treatments all kind of come into this idea of what is the mechanism and what are we treating. And I wonder, as you've been working on this, are there questions or curiosities that you have or things that we could address, because we do, you know, in this room have preclinical experts that are working on eye organoids or working with mouse models. And so when you think about things that can contribute to the way that you interact with vision as an ophthalmologist, what kinds of things come to mind?
Yeah, that's a great question. So definitely, I think, you know, there's both a neurodevelopmental and a neurodegenerative aspect to KIF1A from, you know, what I've seen clinically. You know, some patients, you know, they come in and they, you know, they have signs of optic nerve atrophy, but they're like, you know, it's obviously neurodevelopmental because the nerve looks hypoplastic, which means it looks smaller than you expect it to look, which indicates that it's a developmental issue, not so much like a degenerative issue, because the optic nerve is going to be the same size it's always going to be. It's just going to, it might degenerate, but it's going to still the kind of the outside part of it is still going to stay the same size. So oftentimes you'll see optic nerve hypoplasia, which is like, you know, a smaller than expected optic nerve, and that's developmental. And on the other end of it, there's the neurodegenerative part, which is, you know, you start out with a certain number of optic nerve, you know, the ganglion cells that form the optic nerve, and like, you know, they are, you know, degenerate or get damaged with time. And like, you know, there's that aspect to it too. So there's like a developmental part, and then like you know, the KIF1A gene does something with development, and then also with like maintaining the health of the optic nerve throughout life. So I think it would be really, really interesting, you know, with organoids is like a huge thing now, to see like, you know, do these, you know, these ganglion cells that form the optic nerve, like how do they organize, like what parts, you know, in the very early parts of development, like what exactly is affected. So that's one aspect. And then seeing how these ganglion cells like are maintained, you know, what parts, you know, of KIF1A, like the gene product, is neuroprotective to these ganglion cells. So it's I think it opens up a lot of questions about the role of that gene in, like, you know, both development and maintenance of these ganglion cells. Yeah.
Oh, yeah.
Supplements that you recommend?
Oh, I just asked, are there supplements that you recommend for the eyes for our kids?
At this point, I don't think we have enough evidence to recommend any specific supplements. Generally speaking, if you ask an ophthalmologist just in general, like what can you do to like maintain eye health, it's always things like, you know, wear sunglasses, you know, eat your dark leafy greens, eat fish, like that sort of thing. That all of that is always like great for like eye health. But in terms of like specific supplements for patients with KIF1A, I don't think we really have any evidence for any at this point.
Hi, is there a frequency with which you would suggest visiting an ophthalmologist to follow over time, or would you say the regular kind of schedule is acceptable for KAND?
My sense is like at least every 6 months would be good. But it really depends on, you know, the patient. If they're like going through some sort of like acute change in their vision, then obviously more frequently than every 6 months, and like it needs to be investigated, what's happening. Depends on whether they have any strabismus. They may need to be seen far more frequently if they had strabismus and they're getting patched or they're getting glasses, and the ophthalmologist needs to make sure that they're developing. The frequency also depends on the age. So the younger you are, the more you need to be followed, particularly if you have a risk for strabismus and the eyes not being aligned. So I would say if it, kind of like if you're on the younger end, I would say like, probably at least every 6 months, if not sooner, just to make sure that you're not, the patient's not developing strabismus or the eyes aren't working together or whatever. Because like sometimes these findings can be subtle. And then like, as you get older, then I would say like every 6 months should be good.
I have two questions. So the first is there a pattern where you see the vision change, where could it be for a while it's stable and then declines and then stable, or once you see decline, it continues to decline?
Yeah, that's a great question. So clinical signs of decline and subjective feelings of decline can be very different. So again, going back to like the glaucoma example, patients with glaucoma, like if you follow them clinically, if you look at the cells that make up their optic nerve, it's like, it's dropping pretty linearly, but they're not noticing it until kind of like a critical point, like some sort of threshold where all of a sudden they're noticing that they can't see, even though like they were seeing fine before. But that's because like, the way the eye is built, like there is some kind of like buffer in a way to the way the optic nerve is built. So it kind of depends. It really should be, I think, guided by what the person is saying. Like, what are they having problems? Are you noticing that they're having problems? Are they like, not navigating as well as they can be or were previously? So, so I just want to just want to point out, like, clinically, you may be able to follow it, and like OCT is great for something like that, particularly for the optic nerve, to kind of see if there's like a decline in the thickness of the optic nerve, but that doesn't necessarily translate into the patient seeing worse. So it kind of needs to be followed independently, I would say.
And then the second question is, do you see correlation between the vision change and the other manifestation of the disease, or these sometimes could be completely separate?
You mean the severity of eye findings versus the severity of findings elsewhere in the body, or? So I've seen like a general kind of correlation. Yeah, I've seen like basically patients who have, kind of like are at the more kind of, milder spectrum of things, visually speaking, also tend to be more mildly affected with like, other things such as, neurologically and with their motor function, compared to patients who, are more severely affected with their vision. So I would say it's, I wouldn't say it's like it's 100% correlation, but there's definitely a correlation with the severities.
Hi, Edward was diagnosed with optic nerve atrophy, which is what we've been talking about. And when it was presented to us, they explained it to us that the optic nerve takes pictures and it is pink, which is a healthy nerve. And then a couple of years later, it had died off to a point where it was pale. So therefore, is that something that's quite common, where it can go from being pink and healthy to a few years later, it's now pale and at a point where it's potentially stabilized, because they have said to us that they don't really need to see him again unless we notice anything drastic in his changes of vision.
So optic nerve pallor is one of the findings in optic nerve atrophy, and I also feel like it's one of the more subjective findings. An optic nerve that looks pale to one person isn't necessarily pale to another person, which is why I kind of like, I love things like OCT, because it's objective. You get a number, this is the thickness and this is how it's changed. So yes, optic nerve pallor is a thing, but like, I feel like you can get different degrees of optic nerve pallor. It's not like, pink or it's pale. There's all sorts of things in between. So it's like, it's kind of, I would say, yes, I mean, pallor indicates that something is going on, but I wouldn't rely on it solely to say how much the patient is seeing.
And I think that wraps us up with about a minute to spare. So I want to thank you, Dr. Abdelhakim, for all of your perspective.
Yeah, thank you. Thanks so much.